Hello everyone. I'm going to give you a quick overview about hyperparathyroidism and specifically primary hyperparathyroidism because it came in the exam a couple of times. So actually it comes like investigation, like from outside in the task. There is hyperthyroid hormones and high calcium, and you need to discuss the result with the patients. So like you don't have loss of DD here because the picture is, it could be just one of two, either primary hyperparathyroidism or another condition we're going to speak about right now is called familial hypocalciuric hypercalcemia. It has exactly same blood picture. Sorry, just my, all right, sorry. Okay. So just let's start by the pathophysiology just to help you remember the symptoms and the whole station. So as you know, parathyroid hormone increase osteoclast activities and thus increase bone resorption. So from this just informations, you can remember one of the symptoms of primary hyperparathyroidism. They have osteoporosis. Sometimes in extreme cases could be osteomalacia or bone fractures. They can come with a history of fractures. They also have direct effect on the kidneys to increase the calcium absorptions. So this is also can remind you by the secondary hyperparathyroidism. So secondary hyperparathyroidism, it could be due to secondary causes, one of them renal failure. So if we have renal problems, so it can cause secondary hyperparathyroidism. Sorry, just I'm admitting. All right, so, and also they have indirect role in increase intestinal absorption for the calcium through 25 hydroxylase hydroxy alpha hydroxylase, which is the active form of vitamin D. So also this can remind you with the fact that secondary hyperparathyroidism can cause by vitamin D deficiency. So in our case as well, we can measure vitamin D levels. We will check the renal function test. Okay, so if like this is the normal pathophysiology, but if we have prolonged hypocalcemia, so this can lead to parathyroid hormones being hypertrophied and or hyperplasia, increase in size, and this can result in uncontrolled surge of parathyroid hormone, and this can result in primary hyperparathyroidism. So high levels of calcium can lead to abdominal pain, constipation, renal stones, fatigue, muscle weakness, depression, and poor concentrations. So this is the symptoms of high calcium levels. Yeah, so if we didn't have the investigation in our case, we have just high calcium, so our DD will be a lot, and this is the symptoms. And primary hyperparathyroidism, they present normally by the symptoms of high calcium levels like abdominal pain, constipations, renal stones. Sometimes can be inactive, the renal stones, so may not result in symptoms like hematuria, but sometimes can present with some symptoms, and fatigue, muscle weakness, depression, and poor concentrations. So this is mainly the symptoms of high calcium levels. And sometimes primary hyperparathyroidism can present without symptoms at all. So it could be just incidental finding of high calciums, and then the GB will do the workup and find this primary hyperparathyroidism. And as you know, hyperparathyroidism is divided into 3 subtypes. So we have primary, secondary, and tertiary. Sorry. Okay. So primary hyperparathyroidism, it mainly due to, sorry, the people that's coming, they are distracting me every time. Sorry, just you feel me sometimes. I can't concentrate. So primary hyperthyroidism can result from like parathyroid adenoma or hyperplasia or carcinoma. Also, it can be part of familial hyperparathyroidism, such as MEN1 and 2. And diagnosis, as I said, presence of the symptoms of hypercalcemia, and in addition to like bone fragility and osteoporosis. So we confirm the diagnosis by measuring the calcium and parathyroid hormones. Later on, we speak about the diagnosis again. So this is the other condition, the other DD in our station. So we mainly have, as I said, we have primary hyperparathyroidism. For the picture we had in our case, could be primary hyperparathyroidism, and we will ask about the specifically about the symptoms of primary hyperparathyroidism. We will ask the patient about them, all of them, the symptoms I mentioned now. And in our investigation, we're going to exclude this condition, familiar hypocalciuric hypercalcemia, which result due to calcium sensing receptors disorder. So it is a genetic disorder and being caused by defect in the calcium sensing receptors. So we have these receptors for the calciums in the parathyroid hormone in the kidney and somewhere else, but mainly in the parathyroid glands, sorry, and in the kidneys. So these receptors will sense the levels of the extracellular calciums. So when we have too much calcium in our blood, for example, it will send signal to the parathyroid to reduce the parathyroid hormones, and in the kidney to, if we have too much calcium in our blood, for the kidney, it will reduce the reabsorption of the calcium, so it will increase the excretion of calcium in the urines. However, because those people, they don't sense the calcium in their bloods, they don't have this receptor to sense the level of calcium, so you will find them, they have high parathyroid hormones, and also they have high calcium, and the level of calcium in their urine is low because their body is not working, is not regulating the calcium enough. So what's happening? They don't feel the calcium in their bloods because of the defect of the receptors, in the calcium sensing receptors. So the parathyroid hormone, despite the calcium too high, so the parathyroid hormone supposed to reduce the parathyroid gland supposed to reduce the parathyroid hormones. However, because they cannot feel the calcium, so they have high calcium and high parathyroid hormones, but they have low calcium in their urine, and this is what differentiates them from primary hyperparathyroidism. So in the investigation, we're going to check the urine for 24-hour urinary calcium excretions to see if we find it low, so it means this is the conditions rather than primary hyperparathyroidism. So secondary hyperparathyroidism, as I said, is due to other causes. For example, vitamin D deficiency or malabsorption syndrome or medications. So also you can include this in your history as well. You can ask about in the investigation, for example, we're going to do the renal function and vitamin D levels, but you can ask about malabsorptions in the history, like if she has any chronic diarrhea for any cause or not, and medications. It can come in the past medical history, so you don't need to remember it. Yes, you will ask, are you taking any medication at all or not? So, and what the picture, the blood picture in the secondary hyperparathyroidism. So they have, as I said, they have low vitamin D or problem in their kidney or medication that reduce the calcium. So normally those people, they have very low calciums, and the parathyroid hormone worked very hard to increase the parathyroid hormone. The parathyroid gland was active to compensate the hypocalcemia. So you will find they have high parathyroid hormones levels, but they have normal calciums, because normally, like initially they had low calcium, and the parathyroid glands did its job and normalized the calcium to the right levels. That's why people with secondary hyperparathyroidism, we will find they have normal calcemic hyperparathyroidism. I'm sorry, just whenever I admit someone, I forget what I was saying. Excuse me. All right, so yes, how the diagnosis, how do we do it? So in our case, we don't need to worry if it came the same, because we already have the picture in front of us. So we have the high calcium, it was 3 point something in the case, and we have high parathyroid hormones levels. But if we didn't have it, we have to measure the calcium. So the cutoff point is 2.6 millimole per liters. So if the patient has 2.6 or even 2.5, but has symptoms that indicate primary hyperparathyroidism, we can repeat the calcium again. If the measurement is stayed the same, we can measure parathyroid hormones. So if the parathyroid hormones above the midpoint of the reference range, this indicates primary hyperparathyroidism. We're going to refer to the specialist endocrinologist for further assessment. But if the parathyroid hormones levels below the reference, the lower limit of reference range, yeah, it means low. So we're going to think about other diagnoses such as malignancy. And as I said, we have to exclude familial hypocalciuric hypercalcemia by measuring 24-hour urinary calcium excretions and random renal calcium to creatinine excretion ratio. And yes, it could be a specialist, this part, it could be just a specialist job, but the examiner will be impressed if you tell the patient that your condition, from my assessment, it seems to be like condition called primary hyperparathyroidism, but also we need to exclude another conditions, which is results from genetic defect to the calcium receptor. So the examiner will be, wow, you are so knowledgeable. So they will give you 4 in the management. And sometimes nowadays, because they're trying to change the exam, the patient have this habit. What's the specialist going to do for me? When you ask, do you have any other concern in the end of the session, they will tell you, doctor, what's the specialist they're going to do for me? So we have to be aware a little bit about what's going to happen at the specialist level. So they're going to like, if you already gave them the parathyroid hormone levels and the calcium, they will do another measurement to confirm the diagnosis, and they will be also looking for other comorbidities like complication of parathyroid hormone, primary hyperparathyroidism. So they will check, for example, do DEXA scan to see if there is any osteoporosis or any osteomalacia, and also we'll do ultrasound of the renal tract to check for renal stones. And the treatment is surgery for primary hyperparathyroidism, but the specialist also, before the surgery, they will do preoperative imaging to localize the hyperactive parathyroid hormone glands, because we have 4 parathyroid glands in our body, or sometimes more. Sometimes there is ectopic parathyroid glands. So surgeon needs to do imaging just to find out where exactly the hyperactive parathyroid hormones before they go to surgery. So this is all about the station. I think it's really easy. Just you're going to ask specifically about the symptoms and the symptoms of primary hyperparathyroidism and any other comorbidities. We will you can ask cancer symptoms as well to exclude parathyroid cancer, and like any history of fractures, bone fractures in the past or bone pains, and we will do in our investigations. As I said, we will refer to specialists, and they're going to exclude familial hypocalciuric hypercalcemia, and they, when the hyperparathyroidism being confirmed, they will look for any comorbidities for primary hyperparathyroidism, such as doing DEXA scan to exclude osteoporosis and renal ultrasound to see if there is any renal stones. Treatment is always surgery unless the patient refuses, so there is medications, but they are not as effective as the surgery. So if you have any question, please write down in the chat for me. I'm sorry for the disruption. I just wasn't concentrating well today. Do you have any question regarding the station?